Right. Welcome, everyone. We are so excited to put on this perimenopause event with our panelist speakers here. I am Dr. Betty DeLass. I own Reborn Pelvic Health and Wellness, and I will be the moderator tonight. And we are just going to go round robin around the room, introducing ourselves and our expertise, what company we work for, and we're going to have so much fun learning about all the perimenopausal things. So buckle up, and here we go. Erica, you can start us off.
Absolutely. Well, thank you so much. My name is Erica Lemke. I am a clinical sexologist and sex and relationship coach. I'm based in Murray, Utah, and my company is Sex Coach SLC.
Go ahead, Olivia.
Okay, awesome. Hi, I'm Olivia Hansen. I'm the owner of Wildly Nourished Nutrition. I'm a functional women's health dietitian, and I'm currently completing my certification in mindset and behavior change coaching. So you'll see that I'm really passionate about that as well within my coaching. And I combine evidence-based nutrition with mindset and behavior change support. Instead of asking, why can't you stick to the plan? I want to understand what's getting in the way, create strategies to work for you, and help women build habits they can really maintain over time.
And then Rena.
Hi, I'm Rena Vanzo, licensed and certified genetic counselor. So I help administer hereditary gene testing for things like the BRCA or BRCA1 gene. I am also co-founder and owner of the Boob Bus, Utah's newest mobile mammogram service. 1 in 8 women will be diagnosed with breast cancer in the course of their lifetime. And as it happens, women in Utah are in the bottom 5 states for screening. So we are here to make it a more approachable and pleasant process that more women take advantage of.
Amazing. And Jenn.
Hi, I'm Jenn Gutierrez. I'm a pelvic health physical therapist. I work for Reborn Pelvic Health and Wellness in their Murray clinic. And I also get to be their Director of Clinical Excellence, which means I get to help mentor some of the other therapists, and which I really love. I am really passionate about helping people stay active and doing the things that they love. I often see patients that stop doing the things they love because of leakage, because of urgency, because of prolapse, because of bowel symptoms. And they assume that it's just kind of something that happens with aging. And I love to be able to help them recognize that those things can change, and that they can get back to some of the things that they want to do.
Wonderful. Well, thank you all for being here on our panelist night. We are going to start off with questions, and I'm going to go random directions here. So Jenn, it's coming right back to you. So my first question for you is, as estrogen declines in perimenopause, a lot of women suddenly deal with urgency, leakage, or vaginal dryness for the first time and assume it's just aging. What's actually happening to the pelvic floor and tissues around there? And what can pelvic floor therapy realistically change during this time frame?
So we know that estrogen affects a lot of different areas of the body, but for the area that we're talking about, the pelvic floor, it affects those tissues that are around the bladder. So the bladder itself, the urethra, the vagina, and the vulva. And so then as estrogen declines, then these tissues become thinner, they become drier, and they become more sensitive. And at the same time, then we know that with that change in estrogen, muscles and connective tissues that are throughout the whole body, including the pelvic floor, start to change as well. So good news is that the urgency, leakage, prolapse, and discomfort aren't just things that women have to live with. Pelvic floor physical therapy and occupational therapy can actually really help improve the muscle coordination, the pressure management, bowel and bladder habits, exercise strategies, and so then help these patients return to activity. So as someone's pelvic floor is functioning better, then we know that there's better blood flow to that area. And that helps keep those tissues healthier, helps them become healthier. So it actually can change quite a bit. Sometimes we collaborate with physicians about vaginal estrogen, so topical estrogen. And there are new guidelines that just came out about that in 2025. So hopefully more physicians are aware of that. But oftentimes we're the first one to kind of be discussing that with a patient and saying, you know what, this might be something to have a discussion with, because we don't prescribe, but we work in partnership a lot of times with other physicians that can help with that. Because we know it's not just a muscle issue. So that's kind of where our limitation is as therapists, right? We also have to be looking at the tissues, the hormones, the lifestyle of the patient, and their movement, and all of that just kind of working together. I usually tell women that we won't be able to stop the aging process, but we can we can always improve their function and their quality of life.
Very good. Very good. Amazing. Okay, we are going to jump to Olivia next. And perimenopausal changes how the body handles blood sugar, builds muscle, and holds on to fat. So the kind of some of the old nutrition habits that someone may have been using might stop working. What shifts actually move that needle? And what advice should women just like let go of like, I shouldn't listen to that?
Yeah. There are a lot of changes, right? Estrogen and progesterone influence a lot of our body tissues, and not just, the pelvic floor like we were talking about before. So what works for you in your 20s and 30s may not work in perimenopause, even starting like at the age of 35, right? We can see women starting to see changes in those hormones and into starting perimenopause. Your physiology is changing at that point. So many women become more insulin resistant, like you mentioned, lose muscle more easily, and notice changes in body composition, energy, recovery from workouts, things like that. The biggest shift that tends to move the needle are prioritizing protein. I know we hear protein a ton. It isn't just a trend. There is research behind protein that our bodies don't utilize it as well as we age. And protein also supports maintaining muscle and, gaining muscle, because we can still gain muscle even in perimenopause and menopause. It's just a little bit trickier. We have to change our strategies on workouts too. So especially getting protein earlier in the day, supporting your blood sugar balance. So that is another piece of it, not just muscle, but blood sugar balance. And with those well-rounded meals as well. So protein is a piece of that. Strength training to preserve muscle. So not nutrition, but still I end up talking about a decent amount, eating enough and a wide variety of fiber, because our gut health does change as well. And making sure you're eating enough to fuel your body and your workouts. One thing I encourage women to let go of is the belief that they simply need more willpower, less food, or more cardio. In fact, like most women in perimenopause have a history of chronic dieting, under eating, and those strategies often become far less effective when we see changes in our hormones. So for example, one of the most impactful changes I make with clients is having them eat before a morning workout. So, or even a walk. If we're getting up and walking or going to a workout, many women are surprised by that recommendation, but fueling before exercise, especially for women, there is research looking at like women versus men, and women in perimenopause especially need to be eating before a workout, because our body actually is sent in more into a stress state and holds on to energy or fat more readily. And so we want to fuel before exercise and then prioritize protein after.
Wonderful. Okay, Erica, you're up next with the next question. Shifting hormones in midlife can change desire, arousal, and comfort during sex, and many women feel like something's wrong with them. How do you help clients separate what's physiologically from what's relational or emotional, and where do they even start?
Oh man, yeah. And in my introduction, I should have also mentioned that like my niche is working with women and women and their partners in midlife and beyond. So this is all the work that I'm doing, and I'm finding now perimenopause is starting. Olivia mentioned 35. In my practice, I see women in their early 30s who are experiencing some of these symptoms, and I think just that perimenopausal awareness is huge. I think, and they're so clueless when it comes to this. But I think first of all, it's just normalizing their experience. So many people tell me that I don't feel like myself anymore. I mean, that's probably one of the biggest things that I hear. And so they feel they're broken. And really the reality is that hormonal changes affects, their libido, their desire, their lubrication, orgasm, sleep, energy, all the things, right? So instead of asking them, to ask themselves what's wrong with me, I want to reframe that and say, what is my body trying to tell me? Which I think is a very different way of looking at that. As far as like the physiological, so we're looking at hormones, vaginal dryness, sexual pain, sleep disruption, medications, stress, and just overall health. Relational, so that's a huge one. Communication, which people are either having sex or they're not, but the bigger issue is that they're not talking about it. So that's a huge one. And, intimacy and sex to me is very separate. I think we can have one or the other. Intimacy for me is emotional connection, it's communication, and it's just enjoyment of being with your partner. And so I think that's really important to address that and kind of see that can show up differently. And I think most women in general need to have that sense of intimacy before sex is even on the table for them, which goes along with emotional, right? So they might have body image issues, stress, caregiving demands, both, kids, and maybe they're even helping to take care of their parents, which can be extremely stressful. So stress is such a huge one. And it's multifactorial. It's never just one thing. Yes, it's hormonal, but it's everything else that's showing up, because all the things that are external in the bedroom or out of the bedroom happens and shows up in the bedroom, right? So, I think the good news is identifying these risk factors and letting them be aware that there is hope, I think is really important. And then also, desire just doesn't disappear in midlife. It might just change. And we talk about responsive versus spontaneous desire, talk about Emily Nagoski's work. And a lot of women show up in this phase of life as being more responsive versus spontaneous. So it's educating them on, I'm not broken, nothing's wrong with me. I'm showing up with a different style of desire. And maybe my partner is not in that stage, but then we talk about how they can navigate those common goals, even if they're coming from different pathways. So we want to first, of course, rule out any, physical or medical conditions. Pain is huge, right? So a lot of women endure pain. I see it every single day. And that is the thing that I definitely want them to say, this is what we address first and foremost. So PT, I can't even tell you, probably 3/4 of my female clients I'm referring to physical therapy, because and a lot of them haven't even heard of what a pelvic floor physical therapist is. So it's educating them on, this is what you can help with being the most optimal time in life, and just support, improving sleep, improving stress. Some of those things can be simple, but they're not easy. So, that's a big part of that.
Beautiful. Wonderful. Thank you. Rena, you're up next. Next question. Here we go. Breast cancer risk climbs in exactly the years women are juggling everything else, like Erica just said. And Utah has one of the lowest screening rates in the country, which you also said. What should women in perimenopause understand about their personal risk, screening, and how hormone therapy fits into all of that conversation?
Yeah. Gosh, it's hard to switch from student to answering a question. You ladies are giving such awesome information. I'm like trying to take notes over here. But yeah, that's a great point. 40 is the age when women should start their screening mammograms. That is according to the American Cancer Society. And that is the approximate age whenever the risk of breast cancer in general surmounts the risk of repeated radiation over time. So that is exactly the time. 40, Erica just mentioned some women are starting menopause in 35. So it's all kind of happening at the same time. And we know that 1 in every 8 women will develop breast cancer over the course of their life. And there are a lot of different things that go into that. Your risk may be higher, it may be lower. We do know that some of the bigger drivers in that calculation are, age. Age is one of the greatest things. The risk of breast cancer does increase until it peaks at around age 70 to 74. Also having a family history of breast cancer, whether it's a mother, grandmother, aunt, sister, that can really drive somebody's risk. And also breast density. That's something that the FDA required that mammogram facilities start reporting back to women. So that's been a newer change, and a lot of women aren't too familiar with that yet. So maybe we can talk about that more later. But then also over time, somebody's hormone exposure. Are we being prescribed some of these hormone replacement treatments as we enter perimenopause. And all of those things are incredibly personal for every woman. And again, their risk profile is going to be different based on these things. So I always like to talk to women when they come in, particularly about the family history portion. Are they an eligible candidate for genetic testing? And that could really help us understand what that long-term risk is for them. And that may be more important or a bigger chunk of their risk piece than taking hormone replacement. So everybody is incredibly different from one another when it comes to that. I also want to just point out that when these women are coming in to see us, we have to ask questions about those things, their hormone exposure, their very first menstrual cycle, if they're in perimenopause or when they started menopause. And probably half of the women say, I don't even know if I'm in menopause yet. How would I know that? So I think that's another thing to normalize too, is it can be hard. And some of these symptoms, you know, we may just think are because we're busy. We've been running around this week doing various things for our families. So that's very normal and common for all women to feel.
Thank you. Okay, next one, back to you, Olivia. There's a lot of noise, and you talked about this, about protein, fasting, supplements for women in midlife. Like everyone's trying to sell someone something. So tell us what actually shifts the needle and what should we pay attention to, and what advice should women really like let go of and not listen to that in the noise that's out there?
Yeah, there's definitely a lot of noise right now. You know, what I see happening to women getting overwhelmed by like trying to figure out which supplement, fasting schedule, nutrition trend they should be following, right? The good news is like some of the most effective strategies are actually like the least glamorous out there. Protein, like I mentioned before, I know so many people are like, is that true? Like, is protein really a big deal? It is like one of the areas where the evidence is pretty strong, like I mentioned before. As estrogen declines, right, we see that women become less effective at building and maintaining muscle. Plus, just in general, as we age, we start losing muscle mass in our 30s. And so we're trying to, work against that and slow that process down by getting enough calories and adequate protein throughout the day. And that just helps with like our muscle health, blood sugar regulation, like I mentioned. Fasting is a little more nuanced. I have looked at quite a bit of research that first, a lot of research is not done on women. We don't have as much in perimenopause either, but I have seen the research that we do have shows that long fasting periods are not super helpful for women. There's usually more help, like we see it for men, but their bodies are a lot different. And so fasting for women, longer fasts, like over 14 hours, have not been shown to be super helpful for women and in perimenopause. Fasting for long periods, and especially working out fasted, like I mentioned, can create a stress response in women's bodies. We respond very differently than men. You can see it in even just like a woman and man like working out at the same time in the morning, doing the same workout, and they see massive changes and women don't. And then a lot of times if we change, like, can we get a little fuel before, we do start to see changes. So this just, it can cause the body to like hold on to weight, that stress response. And if that's something that's going on that someone is focusing on in terms of seeing some body composition changes. An overnight fast is totally normal and warranted. And a lot of women, it works really well for to do a 12, maybe 14-hour fast, depending on their schedule and when they're eating throughout the day. And when it comes to supplements, like I always encourage women to be cautious, just because choosing to do a supplement, there's so many that can be helpful for specific symptoms or deficiencies, or as a strategy for maybe someone's trying to build muscle. There are helpful supplements, but we want to make sure we're taking like what makes sense for us. They also just can't replace the basics. We can't out supplement. You've probably heard that, out supplement a bad diet. We really can't. You want to know if you need that supplement in the first place before you're taking it. And plus, supplements aren't regulated. So we don't always know what's in them for sure. And so third-party testing, obviously, and even not ordering off of like Amazon is one of the things that I tell people, at least if you're going to be ordering supplements, they're not stored properly typically. Always, we don't know for sure. And they're sometimes sold by third-party vendors. Most women also just get a bigger return from investment in improving sleep, protein intake, blood sugar balance, and strength training than like buying another supplement. They definitely have a place, but women are going to get more if we make sure those foundations are in place, and then working with a practitioner that is looking at your labs, is looking at your lifestyle, and making sure that it makes sense to take certain supplements.
Awesome. Follow-up question to that.
Yeah.
If a woman only changed 3 things, you have to limit it to 3, about her nutrition during perimenopause, what would you recommend?
If you were changing 3 things, I mean, you probably can guess one. I would hardly say protein is one, especially at breakfast. There are lots of ways to do it, and it works differently for lots of different people. So that's always the tricky part, is like, I can tell you things, I can give you ideas, but we have to find what works for someone, if someone likes something or not, right? And just also what works for how they feel throughout their day. Building balanced meals, including like protein, I mentioned fiber before, is actually really important as well with gut health, and healthy fats to support that blood sugar stability as well as energy throughout the day. And then starting strength training. I know it's not nutrition, they're just like closely linked. Strength training consistently, just to make sure you're maintaining muscle, and the nutrition piece comes in of just eating enough to support those workouts and to make sure that you're building that muscle and recovering.
Perfect. Thank you. Okay, Erica, back to you. Next question. You already alluded to this a little bit, but couples often go through this stage in perimenopause without ever really talking about things openly. How do you go about coaching women to bring their partner into the conversation instead of like quietly pulling away?
I deal with this every day. Yes. I mean, oftentimes couples are having like an entirely different experience and making so many assumptions about the other, right? So most women are withdrawing because this time in life, they don't even know what's happening to them, let alone what their partners are understanding about what's going on with them as well. So I think that's why, again, perimenopause early awareness, I think, is so important. If women understood, I mean, my daughter just turned 24 this week. I'm talking to her about it already, because I want her to be prepared in the future to say, okay, honey, when you start noticing some symptoms, don't wait on this, right? And don't think it's like you're going crazy or anything like that. Like, let's address it now, so then you can be prepared as you get into your 30s. So then you're not blindsided. And I think what happens is that they don't know what's going on. And usually there are a lot of multiple stressors that are going on anyway in life as it does. So that impacts it incredibly. So then they're afraid of disappointing their partners. And then in turn, the partners are feeling rejected. They might take that personally. My spouse, my partner doesn't find me attractive. She doesn't love me anymore. When she's just like, I don't know what's going on what's going on with my body right now, let alone like, I love you, but I don't even know what's going on with me. So how can I even talk about these things and how to address them? So I really want to encourage women to like frame this conversation as a co-creation, like, so it's a team effort, basically, rather than a personal failure. And I think so many would, again, feel like there's something really wrong with me. And, being able to just say, let's get the support that you need. There is help, right? And so, a lot of them say, I don't want sex anymore. I just don't want it. Instead of reframing it again, telling their partners, my body's changing. There are things that are going on. I'm really trying to understand what's happening. I want us to figure out this together. How can you support me? How we can both support each other going through this? And really, so I see a lot of blame. It's definitely a blame game when it comes to this. So instead of blaming, let's look at it with openness and flexibility and curiosity, which I think can have a different lens of then just being so rigid in what might be going on with, this is how sex is supposed to be during this time. But I think when partners actually can understand this about their female partners, that there is a physiological concern going on, that they can stop blaming themselves or taking that personally, which I see so often in my practice. So, and I say sex is not just intercourse. There are a lot of ways to have sex, and sometimes we do really have to talk about what that looks like. And again, I stress that in my world, intimacy and sex can be separate. And I think for a lot of women, they need to feel that sense of intimacy, that connection, that emotional attunement. They want to be seen, they want to feel loved in order for sex to occur. And I think really midlife can be such a beautiful way to kind of reinvigorate, reimagine what life can be. And I think also, this is a time where I think that we also have to grieve our former selves. We have such big expectations about sex, or we used to do this in our past, and why is this not happening? We might have to let go of some of that in order to make room for who we are now and who we want to be in the future.
Beautiful. Follow-up question to that. What would you say is the most common misconception you hear about sex and intimacy during this stage of life?
Yeah, she feels that there's something wrong with her. That again, I talked about that responsive versus spontaneous desire. I'm not spontaneous anymore. What's wrong with me? I'm not normal. Or why don't I feel like I did when I was in my 30s or my 20s or in my 40s? I'm 56, so like I get that. Like I'm different than I was at even last year, for goodness sake. I just turned postmenopausal last month, so lots of changes are going on. But I'm aware. I mean, thankfully, I'm so aware of that for myself. I'm so grateful. But I know so many women are not, and they are just left to figure this out, and they suffer in silence so often, which is so incredibly sad when it doesn't have to be that way. So really just looking at like, okay, if you have a responsive style of desire, let's talk about that. Let's talk about your partner. Let's get your partner involved so your partner can understand what tools might we need to work on to build this better way of being able to function sexually, intimately. Where's the pleasure? Where is the sensuality? I think there are some other things that they can do to really start embracing this new phase of their relationship.
Wonderful. Okay, Rena, back to you. You talked about dense breast tissue. We're going to talk about that again here in this next question. So dense breast tissue is common and can hide things on a standard mammogram. What should women know about breast density and whether they need more than just the basic screening?
Yeah, great question. The number one myth I hear people say is I have dense tissue, so I shouldn't have a mammogram. And that is false. Mammography is still the gold standard in breast screening and should be done every year for every woman from age 40 to about 75. So that is really important, and we do have to let people know that every year. So just to kind of make sure we're all on the same page, there are 4 categories of breast density: A, B, C, and D. It does not correlate at all with cup size. That's that would make sense, but unfortunately they're both alphabetical scales. But A is considered fatty and the least dense, and then all the way through D is extremely dense breast tissue. And so having type C or D classifies a woman as having dense breast tissue. And about half of women, it's about 40 to 45% of all women, have either C or D. So it's not uncommon to have dense breast tissue. But you are right, Betty, that the mammogram does make the mammogram on mammography imaging, cancer is white. Dense tissue is also white. So there is a bit of a masking effect. So every woman that has dense breast tissue should be notified of that, so they have the option to have an additional screening method that could be ultrasound or breast MRI. And on that methodology, that coloring scheme is kind of flipped, where the dense tissue is black and cancer is more white, so it's easier to see. So that's a very generalized explanation. But that said, there are certain findings, calcifications, for example, that cannot be seen on ultrasound. And those are some of the earliest forms of breast cancer that require that mammography. So mammogram every year is absolutely critical. And it's not like other screens, with a colonoscopy, a doctor may say, oh, everything looks good, there were no polyps, you don't need to come in for 5 more years. regardless of what your result shows, even if it's normal or good, women should be having that mammogram every single year. And density does decrease over time. So if a woman comes in and she's a type D, a couple years later, she may have, I guess, moved along that scale to a C or even a B. So it does change over time. Unfortunately, here in our country, screening is often dictated by insurance, and sadly, insurance is not quite covering those additional screening methods today, but I do look for that to change over the next few years in Utah, fortunately.
Awesome. Okay. Follow-up question to a previous question before that I asked is when does it make sense to think about genetic testing either earlier or having additional screening if you have family history or any of that?
Yeah, I think that is a really good question. And so when women go in for a mammogram, nearly all facilities that I know about are doing this risk calculation behind the scenes. It's called the Tyrer-Cuzick risk score. And a bunch of things go into that. I think I mentioned a few earlier: age at your first period, age at menopause, when you had your first child, weight, height, etc. And if that calculation comes back over a certain number, usually 20%. So if someone has a 20% lifetime risk of cancer, they're considered higher risk. So anyone who is over 20% lifetime risk of cancer, remember the average is 1 in 8. So that's about 12.5%. So if somebody is 20% or greater, it's something I generally talk with them about. Also, even if their score is low, but if they had maybe a first or second degree relative with breast cancer, I would at least educate them about it. All of those things kind of play into how likely you are to have a breast cancer gene variant. And by the way, a lot of people have heard about BRCA1, BRCA2, but there are many, many others. Those are the ones that are more commonly seen, but there are other genes, ATM, PALB2, CHEK2, that also increase one's breast cancer risk, along with ovarian cancer, other genes. Even if somebody doesn't have that high of risk, maybe they're adopted and don't know their family history. Maybe they are just somebody who really seeks information and they feel more proactive when they're getting that information. I don't think there's anything wrong with anyone getting that kind of genetic testing because the payoff is so high. The odds may be low that you have one of these gene variants, but if you do, that's going to change everything. Maybe we do a breast image every 6 months instead of once a year, or some women may choose to have a double mastectomy and reduce that breast tissue and reduce that risk. So there are a lot of actionable steps that can be taken when we identify genetic variants. So I think it's smart for everyone to learn about it.
Absolutely. Thank you. Okay, Jen, back to you. Many women, as we all know, think that pelvic floor work is only for like pregnancy and postpartum recovery. Why does it matter just as much in midlife during perimenopause time? And who should be paying attention to, even if they feel just fine right now?
Well, I think pelvic floor work is actually important at all phases of life. But let's see why it's important midlife. I think during midlife is when I think Erica was the one that was mentioning we're so busy. And so we're taking care of kids, we're taking care of the household, we're working, we're caring for parents. And because we're busy, we don't often prioritize ourselves and our own health. And so we might notice these things when they're a little bit small. And then as we start to age and they become a bigger problem, then we might reach out for help. But if we can start some of these things earlier, then we actually are going to have a better health span over our lifespan. I think midlife is really such a key time for us. Like Olivia was talking about, like that's when we're still building a little bit. It's when strength training and cardiovascular exercise, maintaining the bone and muscle health is really critically important. And so, because then we know that really starts to decline a lot more. And so if if someone is either so busy, so they're not doing things, or they're not doing the active things because of leakage or prolapse, then they stop exercising. And that's actually a bigger problem, right? Because then we have more decline in our bone density. There's some interesting studies about that, and looking at how important it is to actually lift heavy. And sometimes if you're leaking, you don't lift heavy, right? And also the importance of weight bearing. And so people who run might be like, I'm leaking, so I'm going to stop running. And the bigger effect of that over these cumulative years are then that we lose so much of that bone density, we lose so much of that muscle. So I think the earlier that people can start working on this, but especially in midlife, I think also our brain and our bodies need patterns, right? And we rely on patterns, and a lot of times nobody teaches us how to breathe properly, right? And so we just breathe the way that we're breathing until suddenly it becomes a problem, because then our pelvic floor isn't moving correctly because of that breathing pattern. We have patterns of pushing inappropriately or breath holding as we're doing some of our things. And so then as our body starts to age, then that actually starts to cause a bigger problem. And we think, what's happened and what's changed? And it's really that we've had the same pattern, but maybe it wasn't a healthy pattern, but now our tissues don't support that. So I think midlife is really kind of a key time to be able to support and manage a lot of these other issues.
Awesome. Follow-up question overall. What's one thing you wish more women knew before they accepted these symptoms as permanent?
We always talk to people and we'll say these symptoms are common, but that doesn't mean that they're normal. And it certainly also, it doesn't mean that we can't treat them, that we can't make it better, right? And so I wish that people kind of knew that. I think some of these things are things that people joke about with others, like, I pee when I laugh, right? And we kind of just joke about that. Or or people will say like, I feel some pressure there, and we kind of we laugh about that because it is common, but that's actually not a normal thing. That's telling us that there's something not functioning well in that area of our body. So I think that's the main thing. You don't have to just tolerate this.
Perfect. Awesome. Okay. Now we're going to do our rapid fire questions. Each of you get one question, and we're going to go boom, boom, boom. So we're going to start with Rena first. What information surprises women most when they meet with a genetic counselor? You're muted.
Thanks. My son was knocking on the door a minute ago. I had to. What surprises women the most when they meet with a genetic counselor? I think a lot of people believe that they have the same fate as those in their family. My mother had breast cancer. I'm definitely going to get breast cancer. My father had colon cancer. I'm definitely going to get it. So I think that they are often surprised, even if there is a gene variant in the family, or they have other risk factors, that most of the time it's usually more likely that they will not develop breast cancer than they will develop breast cancer. So I think math can be hard. I think it's just about explaining it to people in different ways and really hearing their fears and allowing them to talk about that. So the risk usually isn't as high as they expect.
Wonderful. Okay, Olivia, you're next. What's one thing that women can add to their diet to support their bodies? Obviously, you've said protein already, so that is a fair answer if you want to use that again. maybe something you haven't said.
Yeah. I mean, I love this question just because, right, like we commonly think, I think so much nutrition conversation has been focused on what women need to cut out, restrict. Like, I really want to shift that conversation. We want to eat to be strong and to support the activities we want to do, right? And I towards just better supporting our bodies and what we want to do in our life. If there's one thing I'd encourage women to add to their diet is just allowing themselves to have variety, to eat enough of the food and really notice feedback, what is working for my body? How do I feel throughout the day? And it just takes, sometimes we have to tune into that. Sometimes we have been so used to I'm restricting, we actually restrict and then want things more. Like that's how our brain works. And so I encourage people to, right, like still enjoy foods that you want. Like if you're desiring something, find a way to like include it closer to a meal, maybe if it's a dessert, right? That helps with your blood sugar. Or maybe it's having a little bit and allowing yourself to have a little bit where it's not off limits completely. So, and the other thing would be, like I mentioned, not as much, but fiber, just fiber-rich foods of vegetables, berries, beans, like that's variety too, right? Like that's a lot of how we get variety in there. And the fiber is really helpful for gut health, hormone metabolism, blood sugar balance, overall health. So just keeping it simple. Like if you are in a stage of, right, a lot of midlife there's a lot of things going on. And if we're overwhelmed, keeping things simple, finding things that work for you that don't take as much time, or finding workarounds, right? Like I used to do it this way before I had kids or before I was taking care of my parents or whatever it might be. And maybe it just doesn't work anymore. Maybe we have to shift things. So, the biggest takeaway is that women don't need another complicated like protocol. They need strategies that support like the changing physiology and like fits their real life in a sustainable way, not just, oh, I'm having to try something again, start over, right? We hear start over on Monday. Like that's not where we want to be continually, right? We want to find things that work for us long term.
Awesome. Okay, Erica, you're next. What's the one conversation that you think every couple should have during perimenopause?
Well, they need to have a conversation, I think is the start. But I would say, what does intimacy and sex mean to us now, where we are in this phase in life right now? Because it is different than, I think a lot of people just want to, like, we want to go back to how we were. Oftentimes that's not possible. So being brave, being vulnerable, and talking about hard things, I actually think is the better way to deepen intimacy. And I think if they can get brave through tears and snot and whatever it takes to be able to come and say, I'm nervous, but I really want to talk about how we can connect because we really miss each other. And I think even just coming from that place of authenticity can be such a game changer for people. But intimacy also, and when I say intimacy, I'm not talking about sex, although a lot of people put intimacy in the realm of sex, but sex isn't just intercourse. There's a whole menu out there, and I think it's really good to explore everything and get creative. And again, like I said earlier, be curious, be open, be flexible. We don't have to have these myths of that sex is supposed to be a certain way. It's not a step ladder. It's not linear. It can be a full spectrum. Get on the wheel and all these spokes on the hub and like choose something. And whatever you choose, let that be enough. And I think if they can come from that perspective, I think it can be, it can open a lot of doors for them that maybe they previously didn't have.
Awesome. Okay, Jenn, what's one thing every woman can start doing today to support their pelvic floor?
Keep moving. Even simple things, walk, strength train. So start lifting things. Don't be afraid to lift. Breathe, take some time to slow down, and just take a few deep breaths. If during the day, every once in a while, we would just stop and take a couple long, slow breaths, it would give our nervous system a chance to just calm down. And when our nervous system calms down, so does our pelvic floor. And so its function improves. Stay hydrated, but you don't have to be overhydrated. So listen to your body. Pay attention to constipation. I think that's a really big one because bowel health and pelvic floor function are deeply connected. And I think I also just want people, if they're changing their life because of their bowel or their bladder or sexual symptoms, I hope that they won't wait years for asking, before asking for help for that. I hope that people will start asking their doctors to refer them instead of waiting for the doctor to refer them and looking for options. I think it takes a whole team approach. That's why I love that we're all here together, because I think that because nutrition impacts the pelvic floor, it's important to have somebody who can help us with our nutrition because having good relationships is important. I think having someone who can help us with that. I think screenings are important. I think it takes a whole village to be able to support us as women. And so I think we can actually be teaching some of our referring providers instead of being like, why did nobody refer me? I think that we can be looking for opportunities ourselves and then bring that information back to doctors as well, because sometimes they're just not aware of all the things that are out there. So I think it's all just good conversations worth having with each other and with all of our providers.
Awesome. Okay. I have one more question for everyone. Closing question here, more of a personal question. And we'll start with Erica first. As you've grown as a practitioner yourself, how has this evolution shown up in your daily life? How do you approach womanhood?
Oh, man. Well, I just finished a Harvard Medical School program for women's health and wellness, and sexual health is one part of the pie, but it is part of our overall health. But learning about cardiovascular health and metabolic health and our musculoskeletal system and our pelvic floor, and it all matters. And I think when women can understand that they can see themselves as holistic beings and all of it matters, and it's not just not, let's not treat the one symptom and that's it. Let's treat them as a whole person. And I think if we had come from that perspective, then I think that can be so much more valuable and empowering for every single person that we see.
Amazing. Rena, you're up. As you've grown as a practitioner yourself, how has that evolution shown up in your daily life and how you approach womanhood yourself?
Yeah, I think it's about seeing the individual in everyone, and what works for one woman isn't going to work for the next. We have our own beliefs, we have our own physical and mental health. I'm part of a very tight-knit group of girlfriends right now, and some of those are doing very different things in terms of their protein intake and their exercise routine and mental health routine. And I have had to really tell myself, stop comparing. You aren't her, she isn't you. Things are different. You have to find what works for you and what fits into your lifestyle, and something that you can maintain and feel good about.
Awesome. Jenn, same question. As you've grown as a practitioner, how has that evolution shown up in your daily life and how you approach womanhood yourself?
I think I learn a lot from the patients that I see every day and the experiences they have. And I often learn from them things that then have benefited me, because they'll tell me, I saw this provider and they were super helpful. And so then as I start to have struggles with some of those things, like my nutrition as I'm getting older, or my relationships, it's actually from the patients that I see that I've learned quite a bit, and it's changed me as a person. And as I age and I'm experiencing some of these things, it also then helps me relate to patients differently, where when I was younger I was like, I don't know what the big deal is, why is everybody freaking out about perimenopause? And now I'm like, oh my word. So yeah, just continuing to learn and try things out. And I think that's what we're seeing right now with the research. We're kind of testing things out, and we're actually asking for things to be more specific for us as women, which is great because we're not the same as men.
Absolutely. Okay, Olivia, you're going to close this down here with the last question. Same question as all of them. As you've grown as a practitioner, how has that evolution shown up in your daily life and how you approach womanhood yourself?
Yeah, I think the biggest thing for me is realizing health is not about doing everything perfectly. I feel like in the past it was, I felt like I needed to be perfect on certain things, and letting go of that. And it's also understanding just what your body needs in each season of life, right? And learning how to support it. And I've gone on that journey of figuring those things out. And, earlier on, focusing so much on information, giving information, knowing the right nutrition, the right habits, the right, the right things someone should be doing, but really coming around to knowing that, like, sure, knowledge matters, and like I've learned lots of information, but it doesn't create that change. We have to look at the whole person. Like so many of you have already said, we have to look at that whole person. It is about, you know, multiple things, multiple spokes of like their stress, their lifestyle, their responsibilities, their mindset, and what realistically like works for them. And it's not about telling someone what to do. It's about working with them to figure out what works for them, and giving that autonomy, versus, sure, I have all this knowledge, but it may not quite it doesn't translate for everyone, right? And I've just changed how I approach my own life and like womanhood, of like I've become more focused on giving myself the same compassion and support that I encourage for clients to give themselves, you know, and saying, instead of asking like, how can I do more? I'm asking like, what does my body need right now? Not, we don't always have to be doing more. We sometimes actually need to rest and you know, let ourselves do things slowly too. It doesn't have to be instantaneous that things change. So that's just why I love working with women in perimenopause. It's like this season kind of, I think, forces us to slow down and like listen and approach health differently, because there are all these kind of, you know, things happening that we're noticing. And it's not about fighting our bodies. It's about learning how to work with them.
Beautiful, beautiful. Thank you, ladies, so much. You are true experts out in the field here in Utah, and it's been a pleasure to chat with you all. I hope that everyone listening to this has learned so much. It's been a wealth of knowledge, and thank you all so much for being here.
Thank you.
Thank you.
Pleasure.
Thank you, everyone.